Welcome to In the Thick of It from the HCM Society, a show that dives deeply into hypertrophic cardiomyopathy with leading experts in the field. We explore groundbreaking research, new approaches, and other exciting topics. Please enjoy today's discussion supported by an unrestricted educational grant from Bristol Myers Squibb.
Hello, and welcome to the In the Thick of It HCM Society podcast. My name's Dr. Betty Raman, and I'm joined today by Dr. James MacNamara and Professor Martin Maron, who I'll introduce shortly. And today we'll be focusing on a study that has generated a lot of interest in our community, the FORTITUDE-HCM study. I'm thrilled to be joined by Professor Martin Maron, an internationally recognized expert in hypertrophic cardiomyopathy and the director of the Hypertrophic Cardiomyopathy Center at Lahey Clinic. Martin, thank you so much for joining us. It's a real pleasure to have you on this program. Before we dive in, could you give us a one-sentence snapshot of what is FORTITUDE-HCM and why is it a pivotal study?
First of all, it's a pleasure to join you, Betty and James, on the podcast. Because you alluded to, it's great to have the opportunity to talk about this initiative for HCM, which is an initiative really directed at trying to improve the symptom burden and functional capacity in patients with non-obstructive hypertrophic cardiomyopathy. And we may get more into this, but I think the point there is that perhaps non-obstructive HCM really is one of the greatest unmet treatment needs in the disease today. Made a lot of advances in therapies directed at helping patients feel better with obstructive HCM. I think, as we all know, and as well as the patients, the greatest frustration at the moment is really being able to provide improvement in the non-obstructive cohort, which really comprises about 1/3 of the clinically identified HCM population, of course, defined by the absence of mechanical impedance, either at rest or with provocation. And so what FORTITUDE-HCM is specifically a phase 2B study evaluating in a relatively larger population than the phase 2 study called IMPROVE-HCM, a drug called ninerafaxstat, which is a drug within the class called cardiac mitotropes, which are essentially metabolic modulator drugs. And so we've got kind of more of a unique mechanism here for HCM than perhaps some of the other drugs that we can talk about that have been established in this disease, with ninerafaxstat being a metabolic modulator. And the premise here then is that essentially we're evaluating this drug in a symptomatic, functionally limited, non-obstructive HCM population to see if improving cardiac energetics can actually translate into improvements in clinically relevant outcome measures in this population, essentially making patients feel better and function better.
Thank you, Marty. That was a very clear explanation. Now, you're probably aware, that there is a rising interest in cardiac myosin inhibitors and its applications in obstructive hypertrophic cardiomyopathy. How do these drugs compare to cardiac myosin inhibitors? And perhaps we can reflect on the Odyssey-HCM study and the experience we've had with cardiac myosin in non-obstructive HCM population.
Yeah. Well, cardiac myosin inhibitors, which are a relatively newer class of drugs as well, emerging first, of course, into the clinical arena as a treatment that was advanced for symptomatic obstructive HCM with a lot of success, obviously, as we now know, in that patient population. Those by essentially leveraging, in terms of those drugs, their ability to address at the fundamental level of the cardiac sarcomere the number of connections between the myosin and actin interactions, and essentially the drug then modulates contractility in a way to produce favorable hemodynamic changes in the obstructive HCM heart, lower or abolish gradients, and that's translated into a huge symptomatic improvement, with their drugs, and again, creating a lot of, as you mentioned, enthusiasm for them in the HCM space. Based on that success, there has been the idea that they could be potentially evaluated as a therapy in non-obstructive HCM as well, with the idea that by their mechanism of action may actually improve LV relaxation to help improve LV filling, particularly in times of exertion, that would then have a favorable effect on cardiac output that would ultimately translate into clinical benefit in the non-obstructive population through that mechanism of action at acting at the cardiac sarcomere level. And I think, as you mentioned too, that idea or that principle has been tested, initially in a large phase 3 global study with mavacamten in a symptomatic function limited non-obstructive cohort, ODYSSEY-HCM, presented in the public domain a couple months ago and published at that time too in the New England Journal, with an unfortunate and again, disappointing for all of us result where the endpoints of feel and function were not met with mavacamten in this patient population. And so, we still, for that reason, have a lot of unmet need, although I will say that may not be the end of the cardiac myosin inhibitor story in non-obstructive HCM. Of course, we have second-in-class aficamten being evaluated as well in the non-obstructive cohort with a large phase 3 trial called Acacia, which should be available in terms of results sometime in the spring of next year. So you get back to answering the question then in terms of, that was a summary of the myosin inhibitor mechanism action and sort of their efficacy, at least to date. And I think that you can say that ninerafaxstat as a metabolic modulator differs from myosin inhibitors because it has a different mechanism of action, for sure. I mean, it is acting not directly on the cardiac sarcomere, but rather on the myocytes, the cellular system in HCM hearts to alter energetics in the following way. This drug preferentially shifts, in a way, energy utilization at the heart level, at the myocyte level, from free fatty acids to glucose. And glucose, and the message there is that glucose is a much more energy-rich source for the heart, providing it much more ATP than free fatty acids. And the premise there is that with a more energy-rich substrate at the cardiac level, that would have an impact on what is a very energy-dependent process, which of course is diastolic. Okay, and so by improving or being able to mitigate the issue of energy deficiency, which is present in HCM, by providing a greater source of ATP, the idea is that would translate into improvements in LV relaxation again, improvements in LV filling, particularly again with exercise. And that favorable change could result in benefit in terms of making patients feel and function better. So the drugs really differ that way. They're trying to achieve obviously the same pathophysiologic goal in non-obstructive HCM, but they do it through two different mechanisms.
Indeed. And I'd also like to add that there's been work done by investigators in the UK, in Oxford, looking at the effects of ninerafaxstat in HFpEF due to obesity and diabetes, and they were able to show that metabolically this treatment can actually improve myocardial energetics, and this is associated with improved left ventricular stroke volume reserve during exercise, as well as favorable remodeling, all pointing towards improved diastolic dysfunction. So it's really quite exciting. So indeed, we're all looking forward to the study that you're leading. The other question.
Betty, do you mind if I'm going to ask a question to Marty? Do you think that, one of the questions, you talked really nicely about relaxation as a shared ultimate goal of the two drugs.
Right.
What do you think the mitotrope effect of ninerafaxstat would be on systole? Do you think it has the potential to make systolic contraction more efficient as well?
Yeah, I mean, I think it's a great question. I mean, I think we know that, at least based on our current measures of systolic function, ejection fraction and global longitudinal strain, that there doesn't appear to be, any clear impact or effect of ninerafaxstat on systolic function. Okay, which I think on one hand is a favorable thing. Obviously, that's another distinction, by the way, with ninerafaxstat relative to the myosin inhibitors, which of course do affect systolic function. That's how they leverage their benefit in obstructive HCM. Ninerafaxstat doesn't appear to have an impact on contractility, and so that may make it, in a way, a little bit more safer to use, and in terms of monitoring, less monitoring than what we're up against currently with the REMS program, which is a program, of course, around safety of mavacamten in terms of trying to prevent or adjust to systolic dysfunction because of the effect on contractility there. So essentially, we don't believe it has much of effect there, at least not anything that's been seen in the clinical investigations with ninerafaxstat so far in the non-obstructive population.
Interesting. Interesting.
So, Marty, you mentioned that you've done a phase 2A study, the IMPROVE-HCM study. How is this FORTITUDE-HCM study going to be different to or similar to the IMPROVE-HCM study? And yes, what do you expect? What's the difference in the primary endpoint of the two studies?
Sure. So, yeah, maybe to get to that, let me just back up for 1 second and just say for the phase 2 study with ninerafaxstat, as you said, was improve HCM, and as it is for all phase 2 studies, it was one that was focused, first and foremost on safety and tolerability of the drug, but there were efficacy endpoints. And just to mention that for a minute, what improve showed was that ninerafaxstat had the ability to improve in, again, symptomatic, functionally limited non-obstructive HCM patients have the opportunity to improve how patients felt as measured by KCCQ scores, their health status, and also objective improvements in exercise capacity in the form of the submaximal measurement ventilatory efficiency, VEVCA2. And so the signal there, it also was very well tolerated, generally safe, and also very well tolerated as well. And so I think the signal for efficacy in the phase 2A study with its, really good safety profile generated the enthusiasm, I guess, to say it that way, for moving forward with the phase 2B study, which, as you said, is FORTITUDE-HCM. And what FORTITUDE really is a very similar trial design compared to IMPROVE. It's a 12-week evaluation of patients randomized, again, symptomatic, functionally limited, randomized in a one-to-one fashion to ninerafaxstat versus placebo on top of standard of care therapy, followed again for 3 months, and then a short washout period. And again, what we're evaluating here in a larger patient population, I guess that's the big point here. It's a much larger patient population than the phase 2A to get a much more clearer understanding of the potential signal of efficacy here with that larger group in terms of the endpoints that were similar as well to IMPROVE, which will include KCCQ and NYHA for symptom benefit, assessments of symptom benefit, and cardiopulmonary exercise testing for functional improvements, with, again, the primary endpoint being changing KCCQ scores with important secondary endpoints that include change in VEVCO2 and other exercise parameters, as well as other functional changes that may occur too as part of the drug therapy, including changes in left atrial size, wall thickness, and of course, non-invasive measures of diastolic function.
And that's fantastic. And I think one thing, Fortitude is still enrolling, or from my understanding, has just started
Yeah, we
enrolling, right,
just
Marty?
began. That's right. It just began. In fact, we enrolled the first patient for Fortitude a couple of weeks ago, here in Boston. So we're just beginning the initiative.
Yeah. So if someone in the community is listening to this and has a patient, with non-obstructive HCM, what do you think kind of the ideal patient to refer to consideration of Fortitude is?
Yeah, I think we want patients who, are obviously frustrated, in a way with how they feel because of their HCM, who have, preserved systolic function. So you've got to have preserved, systolic function, which is the case for the vast majority of non-obstructive patients. And, you have to be generally otherwise healthy. That's important too. There's some exclusions around other comorbidities and things like that. But mostly it's really about, if I think the message there is that if you're out there listening and particularly if you're a patient, I think, if you're frustrated with how you feel with non-obstructive HCM, despite the therapies that we have, which I'm sure you have tried on, beta blocker or calcium channel blocker, I think it's worth, if you're interested, exploring the idea of this kind of trial and the opportunity for involvement with your HCM cardiologist or your local cardiologist to explore more about the details around the study.
Sounds fantastic. And, the study's just starting. When do you anticipate, or how long do you anticipate this study running?
Well, I think we've probably anticipated about a year and a half of enrollment period for the study, which is a global study, and so it's going to be a big effort. And so I think we're looking at another year and a half for enrollment, and then if everything goes well, then hopefully at some point, after that, soon after that, we would get some idea what the results may look like. But again, that's at least probably 2 years off.
So, Marty, I want to ask you, I mean, there's no way to know this, but I'm going to ask you to speculate a little bit. We've got a lot of trials. Fortitude is a really important one. There are other trials for non-obstructive HCM, SGLT2 inhibitors, things like cardiac myosin inhibitors that we talked about, and hope that, Odyssey was a minor setback and we'll see, different results with Acacia. Do you think there's a role for kind of combination therapy? Do you think we could get to the point where we have GDMT for non-obstructive HCM, and ninerafaxstat could be an important part of that?
Yeah, it's a great question, and I think I would agree with you on the principle that if we had to speculate and look into the future, here, that we could anticipate the idea that non-obstructive HCM in particular, is going to be a situation which is likely going to require more than one drug therapy. I mean, that makes sense because of the complexity of the pathophysiology here. There are perhaps in any individual patient more than one, mechanism, sort of say at play, causing limitation. And, the analogy would be, of course, similar to what has gone on in non-HCM, HFpEF and HFrEF, where we've got, multi-drug therapy approaches for that reason. I don't think that there's any reason to think that non-obstructive HCM would be any different here. And I think that's going to probably be if we had to guess again, that I would suspect that we will see a multi-drug approach to this disease in the future. What it will include, we don't know yet, of course, but the hope will be that that answer will be around the corner for us and the patients soon. But I do agree with you. I don't think one drug is going to do it. And also, I'll say too, to that point, that the myosin inhibitors obviously have been very successful, and so have invasive options for obstructive HCM. But I think, as we all know too, who take care of patients, who are treated with obstructive HCM, not all of them go to being perfect, of course. And I think the option there would be, or the opportunity there, I should say, would be also a multi-drug approach in obstructive HCM too, where drugs that alter, for example, in the case that we're talking about right now, energy utilization could maybe also have an application, in that patient population as well. And so I think that's the vision a little bit here, that it could be applied in both hemodynamic subgroups in a way.
Yeah, that's fantastic. And we're a site for Fortitude. We're really excited about it. We screened our first patient last week, so looking forward to a really productive and hopefully incredibly informative trial.
Just going to ask you, what's the single most important message that you hope listeners of this podcast can take away from studies like FORTITUDE-HCM and studies of novel metabolic treatments in mitotrophs?
Well, I think the message here is that we have to keep an open mind about the idea that novel therapeutic interventions, addressing pathways that are new to us in a way in HCM, in this case energy utilization, the opportunity to give them a shot here in understanding whether or not that is a viable therapeutic target here. And until we do that with these kind of studies, we obviously won't know the answer to that question. But given how big the unmet need is, the complexity of the patient population in terms of what we just talked about numerous different pathways probably leading to the limitation, we've got to have the focus on keeping our minds open to the possibility that these kind of novel targets could have a substantial benefit in these patients. And so that's why we do the studies, right? And so that's why I think we're all looking forward to getting much clearer answer on the ninerafaxstat with the phase 2b study.
Martin, thank you for your insights and for pushing the field forward. This trial gives real hope to patients with non-obstructive HCM.
Thanks,
Yeah, thank you so much. And thank you so much for joining us.
My pleasure. Thank you for having me. Appreciate it.
Thanks for joining us on In the Thick of It, presented by the HCM Society. Make sure to subscribe to our show for more expert insights into the field of hypertrophic cardiomyopathy. For more information, check out the links in our show notes. We hope you will join us again for our next episode.